We are now going to review section 3, cardiac and renal pharmacology. When we look at cardiac pharmacology, of course the autonomic nervous system pharmacology is going to still have a heavy weight. However, one section in cardiac pharmacology will explore another aspect of drugs, which is the electrical effect of drugs. This is why in an initial section we'll look in chapter 1 at fundamental concepts, and particularly we'll look at action potentials. You review a lot of information about action potentials in your physiology book. Here basically we just want to have a quick summary of the various action potentials in the two major types of tissues that we find in the heart. You remember that the heart is composed primarily of muscle type of cells, cardiac myocytes, and those are referred to often as fast response fibers since they are required to conduct action potentials in a very rapid manner so that the entire muscle would depolarize just about at once, and coupling to the electrical activity, as you know well, we need to have the mechanical contraction of that muscle in a very synchronized fashion. Well, when you look at the first diagram in this section, the diagram cardiac action potentials in fast response fibers, you recognize the classic aspect of an action potential of atrial muscle, ventricular muscle, potentially even His-Purkinje type of cell. The first thing we like to check out is what we call the resting membrane potential. The resting membrane potential is the voltage difference that exists between outside and inside the cell at rest when no electrical activity is recorded. And fast response fibers are characterized by a very negative resting membrane potential. It's around minus 90 millivolt on the y-axis. Now, that very negative resting membrane potential gives us two important points here. You must remember from your physio that action potentials are generated once we cross a threshold potential. Well, the more negative the inside of a cell, the farther away it will be from its threshold potential. As a result, it'll make sure that this cell will not be automatically depolarizing. It will have to be basically tickled, if you want, by another tissue, which will be the SA, AV nodal, and specialized cell tissue, in order to reach threshold before the action potential would start. Indeed, it would be pathological and would be actually an arrhythmia for a fast response fiber to be able to reach threshold of itself and eventually fire. Another point of having a very negative resting membrane potential will be the state in which the sodium channels will be found. Voltage-dependent sodium channels will be very much in the ready mode when the membrane potential is extremely negative. And the more sodium channels are in the ready mode, the more likely a huge number of those sodium channels will snap open once we reach threshold. Anyways, key point, resting membrane potential is around minus 90 millivolts in fast response fibers such as muscles, particularly, let's say, ventricular muscle. Now, we know that action potentials are going to be ruled by what the physiologist refers to as a voltage-dependent ion channel. A voltage-dependent ion channel is simply a protein that can open or close in the membrane based on membrane potential differences. That is, potentially depolarization, the cell becoming more positive, might actually open those channels, allowing ions to flux in and out of the actual cell. Otherwise, say for some ion channels, you could imagine potentially hyperpolarization, the cell becoming more negative, resulting in an opening or closing of these ion channels. Voltage dependence refers therefore to the fact that it is not a chemical that will open or close the actual channel, but simply a membrane potential. Now, you know that we have mentioned previously in the autonomic nervous system another type of ion channel. Do you remember the nicotinic acetylcholine receptor? A nicotinic acetylcholine receptor was also an ion channel allowing sodium, potassium to move respectively in and out of cells in order to depolarize tissues such as ganglion or such as skeletal muscle. However, the opening and closing of that channel was ligand mediated. It was through the binding of acetylcholine molecules that we could actually open or close these channels. This means that the group of channels to which nicotinic receptors would belong to is what we refer to as a ligand-gated ion channel. And if you checked out your physiology already, you know that there is yet a third group of ion channels, the one we call ungated. An ungated channel is a channel that is always open. And a parameter of physiology that we use in order to look at the number of open channels in membrane is the parameter of conductance. Ungated channels have maximal conductance at any given time. They never close. Voltage and ligand-gated channels have a variable conductance depending, respectively, on whether membrane potential changes for voltage-gated channel or a ligand binds to the receptor for ligand-gated channels. Well, for action potentials, we are looking at voltage-dependent ion channels. Well, let's go back to the figure. And as we look at this figure, we know that the fast response fiber will eventually be brought to threshold potential thanks to progressive depolarization from nodal tissues. Once the cell reaches a threshold around -80, -70, there will be a rapid phase of depolarization called phase 0. This phase 0 is very much due by far to the opening of the first voltage-dependent channel of relevance, which is a sodium channel. These sodium channels tend to open very fast, hence sometimes the nickname of fast sodium current. And when we open sodium channels, if you want, when there is conductance to sodium in the cell, we know that then the net force on sodium ion, net force being the combination of electrical and concentration forces, again, I will refer you to your cardiac principles in your physio book, the net force to sodium channel is in the direction of moving sodium into the cells. By the way, just for a physio point, why is it that sodium moves into a cell rather than out of a cell? Of course, you're going to tell me because net force is this way, but what is really the reason why sodium moves into the cell? Think of Nernst potential. Ions always move in the direction that will bring the membrane potential closer to their equilibrium potential, closer to their Nernst potential. And the equilibrium potential to sodium is extremely high. Being extremely high, it means positive charges of sodium have to rush into the cell to raise that membrane potential. This is exactly what happens in phase 0. Sodium rushes in, depolarizing the cell. Sodium channels are not the only voltage-dependent channel of relevance here. We also have voltage-dependent calcium channel that will open. However, those calcium channels are much slower in responding to changes in potential. Often, we refer to those calcium channels as slow inward calcium currents. That is meaning that calcium will really kind of trickle in while sodium rushes into the cell. Nonetheless, we're still talking a number of positive charges depolarizing the cell. Notice that phase 0 would bring the cell eventually to nearly positive membrane potential. There's even a little overshoot called phase 1, where physiologists tell us that an entry of chloride and an exit of potassium might play a little role. Phase 1 is not too relevant to us in pharmacology, being that no drugs will interfere with a phase 1. Another key point about ion channel, and this we have mentioned already in the ANS section. Ion channels, any receptors in fact, if they get overstimulated, that is if they get stimulated for long enough, eventually desensitize. They just shut down. Now for voltage-dependent ion channel, we'd rather use another word than desensitize, but it really boils down to the same point. We use the word inactivate. Ultimately, after a few milliseconds of opening and activation, sodium channel will rapidly inactivate. And once they inactivate, they don't work. No more sodium comes into the cell. This is what happens at the level of a plateau phase, where sodium channels are now effectively inactivated and there is no more participation for sodium in the action potential. Rather, what is left is the slow entry of calcium, and very importantly, the participation now of our third main voltage-dependent ion channel, the potassium voltage-dependent channel. Now let's talk a little bit about potassium fluxes. If there is conductance to potassium in a cell, the net force for potassium is outward. That is, potassium would leave the inside of a cell because of a combination effect of electrical and concentration forces on potassium. Ultimately, if you want, potassium has to leave a cell to make it more negative in order to get closer to its equilibrium potential. As a result, you imagine on the diagram that the phase 2, the plateau phase of the action potential, is really an equilibrium between positive charges of calcium getting in a cell and positive charges of potassium leaving this cell. What do you think is eventually going to happen at the end of phase 2? You know, those slow inward calcium currents, they have worked for an awful long time. They might have been slow to turn on, they're also slow to inactivate, but ultimately they will inactivate and shut down. As a result, at the end of phase 2, calcium entry is no longer an issue. All that is left is potassium exiting the cell. As potassium leaves the cell, as positive charges leave the cell, the inside of that cell becomes more and more negative. This is the phase of repolarization, also known as phase 3. Notice that because potassium currents are very much predominant in phase 3, we love to refer to potassium channels as being delayed rectifying type of currents. In other words, they're delayed, they don't start at the initiation of the action potential, and they're rectifying, and that they bring back the membrane potential to minus 90. Once we get back to minus 90, we get back to resting membrane potential, what we call phase 4. You will notice that for fast response fiber, and this holds true literally for ventricular and atrial muscle only, this is a stable phase where the membrane potential remains at minus 90. There is no automaticity under physiological condition to that action potential. Well, in a nutshell, let me summarize again. Upon reaching threshold, an action potential is generated as an all or none response and result in phase 0 from entry of sodium mainly, in phase 2 from a balance between calcium entering and potassium exiting, in phase 3 potassium leaving the cell, returning us back to resting membrane potential. Now, having said this, think a little bit of where our ions are going to be with respect to that cell. Sodium, calcium have rushed into the cell, potassium has been leaving the cell. We know that the normal concentration gradients to these ions are such that sodium, calcium should be mainly found outside of a cell and potassium mainly found inside that cell. Therefore, we will need to pump these ions back into the cells or outside in their respective compartment. You know, this is the job of a major active transporter pump, which is the sodium-potassium ATPase pump. Its big job will be to restore the ionic gradients, and it will take it some time in order for this to happen. This is why we'll talk about refractoriness. I'll show you a slide about refractoriness in a second. Finally, when we look at this action potential, we must start thinking in terms of antiarrhythmics. There is no doubt that if we wanted to slow the rhythm of the heart, and if you want, this is the definition of an antiarrhythmic, slowing the heart could very well be due to interference from drug with those voltage-dependent channel. And any blockade of a voltage-dependent channel should result in a lengthening of the duration of the action potential. Well, as far as phases that are classic targets for antiarrhythmic, phase 0 will very much be a target for sodium channel blockers. Phase 3 will be an important target for potassium channel blockers. We will not see many drugs having significant effect on phase 1 or phase 2. Certainly as far as sodium-potassium ATPase goes, which works all along the actual time scale of the action potential, we'll see also a famous drug which will be digoxin interfering, blocking sodium-potassium ATPase. Well, let's leave the action potential and what it looks like and its mechanism in a cardiac myocyte, and let's now look at the other dramatically different tissue, the specialized cells, of which SA and AV nodal cells will be our main emphasis. When we look at the cardiac action potential on the figure entitled Cardiac Action Potentials in Slow Response Fiber, immediately we see a different shape and therefore different stories to follow here. First point, when we look at nodal type of tissue, notice the resting membrane potential. It is shown to you as being partially depolarized. Again, depolarization means more positive. Hyperpolarization means more negative. Here we're seeing a partially depolarized cell in that the resting membrane potential is close to -70. I will remind you that in fast response fibers it was close to -90. Being partially depolarized obviously means to us that the resting membrane potential is awfully close to the threshold potential. And threshold is this membrane potential that after we cross it would result in the all or none response of an action potential. So it allows us to understand that nodal tissue will tend to fire very readily by itself, a phenomenon that we'll refer to as automaticity. But let's look now at the upstroke of action potential. You notice that the upstroke of the action potential is nowhere as steep and vertical as it was in fast response fibers. There's a good reason for this. Number one, there are few sodium channels available in nodal tissue. Number two, if there were any sodium channels in nodal tissue, they would probably be mainly inactivated from the standpoint that the membrane potential is already partially depolarized. Well, in a nutshell, it means forget about sodium playing any role in the upstroke of the action potential of a nodal tissue. The only thing left, therefore, for the upstroke of the action potential will be the slow inward calcium current. It is from slow entry of calcium that we see the slow but progressive depolarization of nodal cells. That's why we call them slow response fibers. What happens towards the tip of the action potential where the arrow is pointing? You know, calcium channels after a certain number of milliseconds will inactivate and shut down, allowing you therefore to only have repolarization with a voltage-dependent potassium channel, the delayed rectifier potassium current. Well, this results in an action potential for which only two voltage-dependent channels participate, the calcium channel for the upstroke, the potassium channel for the downstroke. You know what it means. If you were thinking about where would sodium channel blockers as antiarrhythmic work, I hope you would be telling me only in fast response fibers. Contrast, if we think of blocking calcium channels and therefore slowing that upstroke further in order to lengthen the action potential duration in nodal cells, then we know we would have a significant antiarrhythmic effect in nodal type of tissue with calcium channel blockade. Finally, if potassium channel blocker are going to be another big group of antiarrhythmic drug working on voltage-dependent channel, potassium channel blockers should work just as well on nodal tissue as they should on fast response fibers. Notice what happens once there is rectification of the membrane potential back down to around -90. The phase 4 in nodal cell is not a stable phase. Unlike the fast response fiber where it stayed horizontal here, you can see clearly a slope bringing back the nodal membrane potential to threshold. This is what we refer to as the pacemaker current. Pacemaker current pretty much is going to be the reason for automaticity in nodal tissue. A pacemaker current is a very complex current. And what is most relevant to us here with pharmacology is the fact that a number of the ion channels participating in the pacemaker current are really not voltage dependent, but rather ligand gated. And you know very well those ligands. Let me just try and tease it out of you. If I was to increase pacemaker current activity, I would reach threshold faster. If nodal cells fire faster, so does the heart, I would increase my heart rate. If I was to slow the pacemaker current, it would take me longer before I'd reach threshold. Therefore, firing of nodal tissue would be much slower. And if firing of nodal tissue is slower, my heart rate would decrease. What were receptors you reviewed with me in the autonomic nervous system that were controlling the heart rate? I sure hope you're thinking out loud. Beta 1 receptor to speed up the heart rate, muscarinic M2 receptor to decrease it. And what were the ligands, respectively, to beta 1 and M2 receptors? Well, of course, for beta 1 receptors, norepinephrine was the ligand from the sympathetic nerve terminals, and for M2 receptors, acetylcholine was the ligand from parasympathetic nerve terminals. How did beta 1 and M2 receptors work? If you remember the molecular pharmacology, beta 1 receptors were GS coupled, raised cyclic AMP in cells, in turn stimulating protein kinase A. Therefore, phosphorylation of intracellular proteins would occur. Contrast M2 receptor for a perfect balance with beta 1 responses were GI coupled. The GI coupling would result in M2 receptors inhibiting the formation of cyclic AMP, lowering its level, thereby lowering protein kinase A activity and decreasing phosphorylation of the same proteins that were previously phosphorylated by beta 1 stimulation. You understand then that thanks to that tight balance between phosphorylated and unphosphorylated proteins, we'll be able this time to interfere with what we call ligand-gated channels. Phosphorylation, if it resulted in opening a channel, surely dephosphorylation will close it. Vice versa, if phosphorylation had resulted in closing a channel, then dephosphorylation should open it. So, having said this, let's try and make it logical. Look back at the diagram. And as you check out the diagram, you notice that in the complex pacemaker current, we will involve sodium, calcium, and potassium. Here, what is shown to you is the pacemaker current being activated, as you would see, with beta 1 stimulation. Indeed, phosphorylation would open channels for sodium and calcium, whereas phosphorylation closes channels to potassium. What is the total result? The net result is if you open sodium and calcium channels by phosphorylation, sodium and calcium follow their flux into the cell, depolarizing it. If phosphorylation closes potassium channel, then of course less potassium leaves the cell. If it stays inside, it further depolarizes the cell. Contrast, an M2 stimulation through GI coupling would result in dephosphorylation of those channels, and not shown in a diagram. Dephosphorylation would close sodium and calcium channel, suppressing entry of those positive ions, but very much through GI coupling, the dephosphorylation would open the potassium channel, resulting in potassium leakage. Losing positive charges, the cell would become more and more negative. Well, how do we boil this down to a conclusion? I think the main conclusion for us right now is that it is the autonomic nervous system that, of course, controls the rate of pacemaker current. And if it's the autonomic nervous system that works on pacemaker current, all of the drugs that worked in the ANS section on either muscarinic or beta 1 receptors will have their critical effect in nodal tissue at the level of pacemaker current. How could you be called an antiarrhythmic? You remember, by definition, something that slows down the rhythm. And to slow down the rhythm, you would want to decrease pacemaker activity. With ANS drugs, you could achieve a decreased pacemaker current by either stimulating muscarinic receptors or blocking beta 1 receptors. What would you choose clinically? Using agonists that have efficacy, that of course will then bind to any other receptors of the same type and cause effects everywhere in the body, or a blocker that has zero efficacy and that only works providing there's an agonist to compete for? Well, I'm sure you're answering to yourself, a blocker will be much safer to use in our patient than an agonist. Certainly, it is far less likely to be associated with side effects. This is why beta blockers, and certainly not muscarinic agonists, are used as also antiarrhythmic. They will work on pacemaker current. A third diagram is represented for you in those general concepts. This is a diagram that shows us the relationship of effective refractory period to action potential duration. Effective refractory period, ERP, to action potential duration, APD. Notice in the diagram also RRP, which stands for relative refractory period. The whole idea stems from the different states ion channels can take. And different states simply means different shapes, different conformation of those channels. Pretty much channels exist only in three shapes. And the three shapes for channels are to be closed, to be open, and surprise, we'll see this in a subsequent diagram, to be inactivated. So closed, opened, inactivated. When a channel is inactivated, the only way it goes back to becoming functional is to get back first to the closed state before it can get activated and opened again and then inactivated. So it goes in an order, and the order is resting closed, activated open, inactivated closed. Then again, resting closed, activated opened, inactivated closed. For voltage-dependent channel, the inactivation occurs after excessive stimulation. Think of the fast response fiber shown in your diagram. You remember how phase 0 was mainly due to sodium entry through voltage-dependent sodium channels. You remember further that those sodium channels, by the end of phase 0, become inactivated. Well, as long as they remain inactivated, there is no way of ever starting another action potential. Sodium will never be able to get in until inactivated channels go back to the resting closed state and restart a complete cycle. This is why we'll say the cell is effectively refractory as long as it remains depolarized. The effective refractory period, therefore, is very, very much tied up to the length of the action potential duration. The longer that duration, the longer the effective refractoriness of the tissue. Antiarrhythmics, by definition, will enhance the action potential duration, and in turn, that increased action potential duration should increase effective refractoriness of tissue. When you increase refractoriness of a tissue, you know that then, no matter what stimulus would be given to that cell, it cannot fire a new action potential. Now, effective refractoriness is not the entire length of the action potential duration. Notice that there is a small period shown towards the right of the figure of relative refractoriness. A relative refractoriness is a state whereby some of the channel have gone back to a ready state, but not all of them. As a result, if you were giving a stronger than normal stimulus to that cell, then it could start firing. That's why it's referred to as relative refractoriness.